But we're going to talk about Globus essentially and how its relation to the inlet patch. As Nick mentioned, my background's more sort of Barrett's esophagus really, and did my PhD in that and set up an endotherapy centre at St Thomas's. But due to the use of radiofrequency ablation for Barrett's, that's why I first got into the inlet patch story. But I'm just going to globally talk about Globus. These are my disclosures. And how it affects us. I see we've got ENT, respiratory, gastroenterologists and upper GI surgeons in the room. And essentially this affects all of us because Globus is a very, very common presentation to these clinics. And essentially it's a feeling of a ball in the back of the throat, a non-painful sensation is demonstrated here. There are other associated symptoms such as cough, hoarseness. This talk from a couple of years ago is when our former Prime Minister was having particularly bad symptoms at the time. And it's a big problem. So GPs will see this quite commonly in their clinics. It represents 4% of all ENT referrals. In the general population, almost half the population will have Globus at some point. And the condition is very durable. So those patients will have persistent symptoms. And you'll see patients who have symptoms for 3 years. They've had several investigations over those time periods. Who do they see? Well, I think quite commonly ENT is the first port of call, clearly to rule out any head and neck cancers or other laryngeal pathology. But often no cause is found, or the ENT find laryngeal edema. Laryngeal edema is a pretty soft sign, though, and you can see it in healthy controls in this study at 93% of the time. Then they'll have a trial of PPI often, and then there'll be no improvement in the majority. And then they're referred to a gastroenterologist for investigation. And the question is this some underlying GI pathology like GORD or a motility disorder, or is this functional? So just going back a step, and I take Phil's point on how we choose our patients for trials. So this is a trial that Janet Wilson has finished, but it's not yet been published, on PPIs. And it is a trial of PPIs in throat symptoms, and all patients had a 4-month course, so quite a long course of high-dose PPI, 30 milligrams BD of lansoprazole, versus placebo. And this was carried out in 8 UK sites around 2014 to 2017. All had the reflux symptom index scores and various other questionnaires. And it was a big study, 1,400 patients screened and 350 also randomized. But you can see from these data that there was no difference between the PPI group and the placebo group. And in actual fact, the placebo response and the PPI response is about the same, about 25%. And we see this in other studies of throat symptoms, and certainly I think Dr. George will be talking later about cough, also and in Globus patients as well. PPIs tend to be about 20-25% effective. And the criticism of this study is that none of them had a gastroscopy or a transnasal endoscopy prior to enrollment, and certainly none had physiology. So we don't really know who they were treating or what they were treating. Now, the Rome 4 diagnostic criteria, this is the functional group that developed guidelines for functional diseases. Rome 4 criteria for Globus came out in 2016. And it was really to set out what Globus is, so a persistent, non-painful sensation of a lump in that area in the throat, and with a normal laryngoscopy and endoscopy. I'll come back to the endoscopy side. Absence of reflux or eosinophilic esophagitis is the cause of the symptom. Now, this is just to say, this is an important and difficult sometimes a thing to rule out, is whether this is EOE or GORD. often there's classical signs of eosinophilic esophagitis when you look down endoscopically, and often they do present with dysphagia, but Globus can be a presenting symptom of EOE. And likewise, dysphagia can be a very common presentation of reflux disease. And the predominance between males and females is not that much difference between the two groups. Slightly older in the reflux population, but we're seeing younger people with GORD. pH testing is interesting because we do see positive reflux testing in patients with EOE. And even the eosinophil count can be a bit daunting because reflux patients can have low-level eosinophilia. So this is a tricky group of seeing. I mean, this is a classic example of patients with EOE. You see the exudates, edema, the rings, those furrows, which always look a bit more pronounced under narrowband imaging. But those two groups are quite difficult to distinguish. But either way, they can both cause Globus, so it's important to rule those out. And then there's motility disorders. So these can also lead to Globus sensation. So as well as having a good endoscopy, it's maybe important to have high-resolution manometry. And certainly in this study, where they looked at a meta-analysis of several studies on patients with Globus, almost 10% had achalasia, 15% had ineffective motility, and then half were normal. But the addition to the Rome criteria from Rome 3 from a few years previously was about the inlet patch in the proximal esophagus. And the reason they put this in is to move things forwards into how we understand this and how we treat it. So what is an inlet patch? Hopefully all of you would have seen one, but they are sometimes quite difficult to spot. They're in the upper esophagus, just below cricopharyngeus, so very high up. And anybody who's done an unsedated endoscopy, this is not the sort of area you want to linger in. So it is much easier to do under sedation. It was first described 200 years ago. They can be quite large. They can affect either wall. They can be slightly raised or flat. And they can often have surrounding inflammation due to acid production. The reason they occur is genetic. So essentially there's a coding system for your esophagus. Your esophagus starts off as gastric mucosa, and then at sort of the 11th week it turns into squamous mucosa, and it's run by these homeobox genes. So the homeobox genes will turn on and off to change tissue development. And essentially if one of the genes doesn't fire correctly, an area of residual tissue will be left behind. And as I mentioned, this is going back a bit, is your developmental biology. So this Professor Slack, this is the reason I first got into Inlet Patches, because he was giving a talk about Barrett's esophagus and then went back and talked about embryology and the inlet patches and whether there's a link between the two. And as I said, it's the native esophagus starts off as columnar and then changes to squamous. So how common is it? Well, endoscopic studies are quite difficult to interpret because there's a miss rate, but we think it's up to about 10% of patients with who have an endoscopy will have an inlet patch. Overall prevalence is probably more like 5%, and that was in a series of autopsies in children. So that's why we know this is a congenital anomaly that happens from birth. In this study of PDT, which we no longer use for Barrett's esophagus, but obviously you're looking quite carefully when you're doing PDT, they found it in up to a third, questioning the link between whether there is a more prevalence in patients with Barrett's than the general population, but I don't think that's really been established. So what about when ENT start doing transnasal studies? This is becoming quite common now. They're going slightly further than the normal laryngoscopy and doing a transnasal. Interestingly, in this cohort of patients where ENT have looked, they didn't find any inlet patches at all. We found things like Barrett's esophagus, Candida, diverticulum, but no inlet patches, which is surprising. And I think it may be the technology that they had, the older T&E scopes, or they just weren't looking at that area. We've started doing transnasal at Guy's and St Thomas's really to take the pressure off the endoscopy department due to the COVID pandemic. And it's been very successful. So we essentially have taken it outside of the endoscopy department. We're using a bowel prep room in the evenings. And you can do it without sedation. You only need one other nurse, and it's very quick for the patients, and they're in and out, so they don't linger in the waiting area. And so far, this is data from the middle before the lockdown. We've doubled that now, but had 86 patients, and we did a visual analog score on all of them, and about almost a third had Globus sensation who were referred in, and 10% of the overall population of T&E patients had an inlet patch. So we were picking up 10% of the time, and it seems to be more prevalent in the Globus cohort, but this was a small group of patients. It's not been published yet, and it wasn't significant. What about when we do a Bravo? So one of the sort of one-stop shop techniques to investigate patients with Globus and to rule out EOE, to rule out reflux, is to do an endoscopy with a Bravo. And in this, and the endoscopists who are doing Bravo, there were only 3 or 4 endoscopists in our department who do Bravo, and they all have an esophageal interest. So they're looking for inlet patch. And actually, we've also got a dedicated reporting tool that says inlet patch, yes or no. So you have to put something in. And in this cohort, we had a rate of 7% who had an inlet patch. Interestingly, a huge number of these patients with reflux described Globus, almost 3/4. And in this group, we did find a significant increase in patients with Globus rather than without. And that's just in press at the moment. So how do you look? From the bite guard, it's about 15 to 20 centimetres. So it's at the level of cricopharyngeus, sometimes above. They're very tricky to spot, but usually just below. You really need to be careful. So in white light endoscopy, they're very subtle. We've often said, oh, they've got Barrett's in the upper esophagus. It's kind of what it looks like. But when you pop the scope onto narrowband imaging, they sort of light up. They're much easier to see. So you can see the brown area here of the inlet patch and the green squamous mucosa. This is a pentat system. It's also quite nice. That's iScan. And Fuji ones are quite good at looking at it as well. But it's really about awareness. And Buscopan's quite helpful because that does relax the upper esophageal sphincter. And particularly when we're treating these, it's quite useful for visualization. But really decent sedation with fentanyl-midazolam is optimal here. And there's one circular one with a lady who had dysphagia. What do we find when we take a biopsy? I wouldn't normally recommend taking a biopsy because they're not precancerous, essentially. We have seen intestinal metaplasia in them, but that's quite rare. Most of the time, it's just either fundic mucosa or cardiotype mucosa, and they produce both acid and mucus. So you get the parietal and chief cells producing acid, but the cardiomucosa produces the mucus. Quite common to get inflammation on biopsy around of the patch and also the adjacent structures. And they do produce acid for sure. So this is a study, very old study now, but looked at stimulating the inlet patch with pentagastrin, which is now no longer, tetragastrin, which is now no longer available. But you can see this is without stimulation, and then they give the tetragastrin, you see this big drop in the pH. And this is sometimes why the dual probe esophageal physiology doesn't quite work, because there's sort of no stimulation at the time. So you might get a negative test for that, but I wouldn't be put off treating a patient with symptoms without acid exposure, but it's quite nice to see acid production from the patch. And this is one of the patients from a trial patient, and you can see there's a dual sensor here. So there's the upper probe and the lower part, and there's a big drop in the pH proximally and none distally, essentially ruling out reflux as a cause, but confirming that the patch is the cause and not just an innocent bystander. Now, sometimes they do respond to PPI, as I mentioned, despite the placebo effect, and that's plausible because they do produce acid. And certainly if there's a lot of inflammation at the time of endoscopy on biopsy, it's worth a trial of PPI, but often they don't. Usually the globus is more to the mucus secretion that PPIs have no effect on. So what else can we do? Well, this was a sort of proof of concept in 2006, treating with APC. And you can see what they've done here. They've got a cap-assisted APC. APC is really quite difficult to use in the proximal esophagus. It's quite unstable. And, you know, with a point and shoot technique with APC, you've got to be very, very careful up there. But you can do it, and it's actually quite effective. So in this pilot study, all the patients had an improvement in their symptoms. And then they went on to publish the smallest randomized control trial ever in gastroenterology with just 21 patients. And 9 out of 11 had a response rate, and there was no placebo effect in the control group. So highly effective. We've moved on from APC in Barrett's esophagus. We do use it occasionally to touch up some islands, but generally we use this device, radiofrequency ablation. Positively and negatively charged electrodes squashed close together, which creates a sort of frictional heat, vaporizes the tissue, and you get a very controlled depth of ablation. It really just goes down to 0.5 millimeter. So before the submucosa, and therefore you reduce the risk of stricturing. The problem with APC is it's very dependent on how much energy you're putting in. So when I'm APing inlet patches, I only use 30 watts up there. You don't need any more than that. I tend to turn the flow rate down to 1.2. You don't need any more than that. It causes problems. But it's very difficult to control the depths because it depends how close to the tissue you are. Whereas with radiofrequency ablation, there's no need for that. It's all controlled by the generator. And as I said, we've been using this to treat Barrett's with dysplasia for 13 years. So we thought, let's do it for the inlet patch. So this was the first time this device was used. We published it in GI endoscopy about 4 years ago now. And all patients had symptoms. We didn't confine it to Globus. It was Globus, cough, sore throat, hoarseness, so general throat symptoms. But they all had to have histological confirmation and symptoms not or partially responsive to PPI. We stopped their PPI. They had a questionnaire. They had an ablation, and then had a rescue therapy if the patch was still there and they were still symptomatic. And then we followed them up with physiology studies at 1 year. And these were the endpoints. So we wanted to see complete squamous regeneration of the inlet patch, and if not complete, how much had gone, and then also assess their pH and any adverse events. This is the visual analog score. It's quite simple. It's essentially the same as the one that was used in the APC studies, 0 to 10 centimeters, so you can grade Globus, sore throat. This is one of the treatments. So now, as we first go into the upper esophagus, it all looks pretty plain and we can't really see much going on. There's a bit of fluid there. And then as you draw back slowly, you start to see, as soon as you put narrowband on, you see the size of the problem. There's these two very large inlet patches. Now, this patient's quite interesting. So he'd had fundoplication for throat symptoms, really. He was also getting reflux. The reflux had entirely resolved with the fundoplication, but his throat symptoms remained. And this had not been diagnosed prior, despite him having several endoscopies. So you can see how important the narrowband is of picking this up. This is the device. So it goes through the scope. It's very easy to control in the upper esophagus because it's got a sort of one-to-one torque. So you can twist it around quite nicely. It's quite small, so sort of 1 centimetre size, but it has a very nice controlled depth. So you can see it takes, this was quite a big patch, so it takes a bit of time, but you can get around quite nicely with the tissue, lay it on, and you're looking for this sort of, the effect afterwards is sort of like a whitish, almost ulcerative effect. And you can see that working around the inlet patch there. So that's what it looks like once the treatment's completed. This is all done under sedation. And this is what it looks like as it's healing. So this is the initial treatment response as you've seen in the video. This is 3 months later. So the patch is almost completely gone with squamous regeneration around it. Second treatment, and then you can see the slight scarring there, but there's no stricturing. Stricturing is very, very, very unlikely in this because we're not treating more than 2/3 of the clot face, as it were. So these were the results from the pilot study. Almost an immediate response after first treatment, and then second treatment if required, and a significant improvement in globus, and also sore throat and cough, which is durable out to 1 year. And if you look at other studies, all on APC, some in pediatrics, some in adult, you'll see similar results of around an 80% response rate in symptoms in this patient cohort. But these are small numbers. Overall, that's still only 100 patients. And the limitations was it's single center, just me doing it. It's a pilot study. So we've moved on and we've commenced this randomized controlled trial against a sham procedure. So we've got 50 patients planned. So far we've treated 25 and COVID's just put the brakes on everything basically, which is a shame, but we're halfway through and those half have actually gone through their entire treatment. The sham group really do not know anything about it. They're giving sedation. We play a sort of sound effect to sound like the RFA generator going off, and then they're not told anything, they go home. 6 months later, then they're offered crossover to have the treatment, and we've crossed over about 8 out of the 12 who have been randomized to sham so far. But we're still going, and we're hoping to start soon in Southampton and possibly Liverpool in the new year. And if you do have these patients, I mean, this trial, we went a bit more for the Globus patients because it looks like those are the ones who really do the best. So they have to have Globus more than 50 on their visual analog score, and no history of other contraindications like varices or previous chemotherapy, chemoradiotherapy, and no history of dysplasia. And they get an ENT review, esophageal physiology, and an esophageal biopsy series to rule out EOE. So if you do have patients like this, do email me. I guess we all get to this point though, when you may have even treated their inlet patch and they've still got symptoms, or they've never had one in the first place and you've ruled everything out. And this is probably the most difficult group to treat. I've not had a lot of success with gabapentin, to be honest, even though the literature says up to 2/3 get better. Nortriptylin's quite good, particularly you can go up to very high doses of nortriptylin, and also I've had some patients improve with citalopram. Psychologist review is important, but often they have other functional GI disorders that coexist. So I'll stop there, but in summary, it's very common to see Globus as a gastroenterologist. I think even more so as we work together with ENT and respiratory. It's really important to do a high quality endoscopy. These inlet patches are often missed. It's often do it again if they've had an unsedated endoscopy. Physiology has a role for sure, and I think should be considered in those with persistent symptoms in a normal OGD. And I think Bravo is very useful in that sense, as you can recheck for the inlet patch at the same time. And ablation is emerging technology, which seems very safe and effective. This was pre-COVID, this is post-COVID, but we're still going. Thank you.
That's fascinating. What's interesting is, isn't it, is that it was first described 200 odd years ago, and only now in the last few years are we starting to recognize that it might have some clinical relevance. So fascinating. We've got a few questions. So firstly, Adam asks the obvious question: if this, presumably the symptoms caused by the inlet patch is because of acid secretion, would you not expect PPIs to help?
Yeah, and I think sometimes they do. I mean, you know, that 30% placebo, you know, how many of those had an inlet patch that was causing their throat symptoms? They can help, and I think it's a very reasonable strategy to try it. Two caveats. One is, when you're on a PPI, it may be treating other things that you'll miss at endoscopy. So if you have an ENT referral for a patient with Globus and you scope them and they're on PPI, I mean, I've had patients like this. They've had eosinophilic esophagitis and it's been missed because the EOE is being treated by the PPI. So you're kind of sort of missing the pathology that they actually need to be treating in the long term. And the second thing is, patients don't want to be on long-term PPIs often. I think this is a thing that Phil was alluding to more recently, that long-term PPI use, I mean, you know, it's people don't want to be on them. So I'm not sure it's a good long-term strategy, but certainly in the short term, I think, yeah, why not? It can certainly help.
A question from, where did I say it? Yes, from Julian. He says, if people have these all their lives because they're genetic, why do people present at some discrete point in their life with the symptoms?
Yeah, that's a tricky. I get asked this a lot. It's a really tricky question because they have had it from birth, but the average presenting age is like in their 50s and 60s. It may have something to do with the upper esophageal sphincter relaxing over time. So there are some studies to suggest that the tightness of the upper esophageal sphincter there relaxes over a period as you get older. There's been some interesting work on the menopause and how that affects is more common in women presenting post-menopause. But the short answer is we don't really know why patients present later on in life. And there are pediatric populations that they've treated. There are people in their 20s. But, you know, sore throat, feeling of something there, they may just not seek medical help.
Yeah. So a typically slightly esoteric and lateral thinking question from a physician. Can you talk about H. pylori infection of the patch and its impact? And that's from Kanesh. Yes,
yeah. So there's been studies on H. pylori in inlet patches. And in fact, like if you have an H. pylori, 70% of the time it also affects the patch. So if you flow test the patch, it will be positive. And there is some benefit from treating patients with H. pylori first to see if that reduces acid secretion from the patch and therefore improves their symptoms. So yeah, it's definitely worthwhile testing their gastric. I wouldn't biopsy the inlet patch for the flow. I'd just do a normal flow test.
Yeah, of course. I suppose the problem is that clearly, given what it seems to be their prevalence, they're identified only rarely.
Exactly.
Yeah. There's the question about pH measurements and reflux testing. Is there any data regarding whether it can influence results? Can it lead to false positives in terms of gastroesophageal reflux?
It's quite tricky, the physiology. I mean, we've done, I don't know, probably about 40 physiology studies on patients with inlet patches now. And maybe, we've got about 10 who have had a positive test out of 40. But a lot of them have got better following ablation. So I wouldn't use it to rule out treatment. And the strategy I tend to use is they come and we say, well, look, you may have reflux as well, but we'll treat the inlet patch first because it's a very low risk approach. And if your symptoms persist despite the inlet patch being removed, because it will go, then we could think about going down the reflux route.
Yeah. So very quickly, just a couple more. So Majid asked, and I think you've probably just answered this question, would you regard identification of an inlet patch as a relative contraindication to proceeding with anti-reflux surgery, given on the basis that the reflux has been diagnosed on pH test? But I guess what you're saying is you treat the inlet patch first, if their symptoms predominantly laryngopharyngeal, and then reassess.
Yeah, exactly.
Yeah. Okay. And Sanjay says, how many patients in these inlet series are overweight or obese?
Not in my experience. I don't know about the other studies, but in our group, there was no influence on obesity or anything like that. It's not your typical Barrett's group or your reflux group of patients.
Yeah. Okay. And the very, very quick last one, which will probably be a yes or no. Phil says, is there any role for APC now?
I think there is, if in the right hands, because they're both doing the same thing. And I think if you're very proficient in APC, it's a lot cheaper, basically. RFA is quite expensive, and it's difficult to get it in the NHS at the moment, which is why we're doing the trial to see if the NICE approval can widen for more than just Barrett's with dysplasia. So if you have APC skill set, then yeah, sure. But the very big ones, I think treat them with RFA first, get them down to a reasonable size, and then finish the job with APC.